All right, so a little bit of housekeeping. So we're gonna be transitioning from speaker to speaker. So as we transition, we'll be sharing screen and going between just to facilitate. So while the speaker is on, if everybody else can mute their microphone on their computers, that'd be great. And then for the Q&A should be moderated by Sanj Kakar. If you could send the questions to him via chat, that we try and avoid people talking over each other. But we're gonna go ahead and get started. So I'm gonna share my screen here. Right, so welcome everybody to the inaugural, the first Hand Fellowship virtual debate and case discussion. So we have 4 fellows participating today. Really want to thank all the faculty from various institutions for agreeing to do this and your enthusiasm and contribution to make this happen. So it'll be round 1 between the fellows, and the topic this week will be on proximal pole scaphoid reconstruction. So I think this has been a really difficult time for all of us. I think, across the country, elective surgeries and cases are suspended. So as far as education, we're not really getting the benefit of training our fellows in the OR and in clinic. I think a lot of institutions and organizations have been very generous with webinars to the Academy, Hand Society, Hand Association, and several implant companies to really try and continue education. Hopefully this really augments that experience for everybody. Hopefully this is interactive, engaging, a little bit of friendly competition between the fellows and institutions. And really want to acknowledge some of our colleagues across the country who've been able to participate in some of the fellowship conferences from other institutions, including the Mayo Clinic in Stanford. So this has really been a great time for everybody to try and find creative ways to engage and stay connected to your colleagues. And I think Zoom happy hour has become a very popular phrase nowadays. I think it's also a really great time to see the generosity of industry. Starbucks offered free coffee to healthcare workers. If you guys saw this by Lin-Manuel Miranda, so the entire cast of Hamilton actually did a Zoom performance for a little girl. And there's a couple in Virginia who actually set up a stand for free food for all the truckers. So again, just a lot of generosity all around for everybody, just being giving. Though it's a very difficult time for everybody. And celebrities are certainly being very generous as well. For those that don't know, so our very own Hand Society member, Dr. Barrett, has started the Double Play program to really give away, to give back to the restaurants so they could sustain their workers, but also give to folks who don't have the means for buying food and meals. So I think everybody's really doing what they can to try and make the best of the situation. So on to the case presentation. So as we all know, proximal pole scaphoid is very challenging. This is a kind of a case example of a patient who had an injury about a year ago, pain 6 out of 10, no prior treatment. So the challenge we have here, it's a really small bone. It's very irregular shaped. People describe it as a cashew, very poor blood supply. So if we look at this case here, your options are trying to fixate that directly with some type of bone grafting, vascularized or non-vascularized bone grafting, versus really looking at it saying, you know what, it's not really salvageable. We have to do some type of osteochondral reconstruction. It's too small to really try and put it together. So this case, we did a 1-2 ICSRA with a small screw and a K-wire just provide a little bit of derotation. I think it's certainly good to be lucky. This one healed quite well despite a very small piece of bone with a high risk of AVN and non-union. So the case for the panel is now you have an 18-year-old with a hockey injury that's 2 years ago. Now you're really dealing with a really small shell. Now it's a 3 millimeter, maybe 4 millimeter osteochondral shell of that proximal pole. So this is intraoperatively what we're dealing with, a very, very small proximal pole. By the time we kind of decorticate, really not a whole lot to work with. And then there's an example like this where a patient comes in, there's really no proximal pole. Somehow it's completely resorbed and completely gone. So not a whole lot to work with. But really the case we're working with is the case here. What do you do now? So our 4 panelists, we have Mary Kate Thayer, who's out of Curtis. She'll be mentored by Dr. Higgins, followed by Chelsea Bowe out of University of Washington, mentored by myself. Jacob Gire, from Stanford, mentored by Dr. Yao, and Kate Bellevue, mentored by Mark Richard. So we're looking at kind of 4 different perspectives: vascularized MFT, proximal hamate, rib allograft, or autograft, versus trying to fix it with some type of bone graft fixation. And Dr. Sanj Kakar will be moderating us for the Mayo Clinic. Right. Take it away, Mary Kate.
All right, let me share my screen here.
Yeah, let me stop share here.
All right. So I'm Mary Kate Thayer, as introduced by Dr. Huang. I'm one of the current fellows at the Curtis National Hand Center. With Dr. Higgins as my mentor, I'll be presenting the medial femoral trochlea free osteochondral flap, or what we'll call the MFT, as the solution for the proximal pole scaphoid nonunion presented. Dr. Huang described a young patient with a nonunion of a very small proximal pole fracture. Salvage procedures such as four-corner fusion and PRCs are typically avoided in this population, as their longevity and ability to meet high functional demands are not ideal. First, we must decide, as mentioned by Dr. Huang, whether this fracture can be fixed. We will often try ORIF first in these small proximal pole fractures, even if there's a risk of failure, and especially in younger patients, to see if we can get by without reconstruction. However, if there's fragmentation of the proximal pole, the piece is too small to fix, or prior attempt at ORIF has failed, we consider this non-salvageable. We propose that an excellent solution for this scenario is the MFT. The goals of this operation include restoring scaphoid anatomy, articular cartilage, and carpal alignment, all while converting the nonunion to a waist-level osteosynthesis with a new imported blood supply. This is an especially great option in the revision surgery scenario. We will use a case example to describe the MFT. These are the injury and postoperative films from a 27-year-old male who sustained a proximal pole scaphoid fracture back in 2017. He was treated at an outside institution with ORIF and bone grafting. He presented to us at about 6 months after surgery with a painful nonunion of his proximal pole, shown here in both his CT scan and x-rays. After a discussion of options, we proceeded with an MFT. Now for a brief summary of the procedure. The flap harvest and wrist preparation can begin simultaneously if 2 surgeon teams are available. The MFT is typically perfused by the transverse branch of the descending geniculate artery. This pedicle is harvested and can be traced back to the DGA's origin at Hunter's Canal for maximal length. Here you can see a photograph of a harvested MFT with its pedicle. Please note this is an older photograph of the harvest, and now we use a much smaller 7.5 centimeter incision. On the right, you see the excised proximal pole. Note that the acetabulum of the scaphoid in its articulation with the capitate is preserved. The MFT only brings with it 1 cartilage surface that articulates with the radius, so this acetabulum should be maintained. Once the harvest is complete and the wrist prepared, the flap is transported to the wrist, inset, and fixed with a single cannulated screw. The screw is often not in a center-center axis, but is instead more vertical in order to obtain the best bone purchase, especially in a revision scenario. It should also ideally be perpendicular to the osteosynthesis site. We also pay close attention to carpal malalignment, especially lunate extension, and correct this prior to fixation. Once happy with the carpentry, we proceed to the microvascular anastomosis, and lastly, closure. These are the first in-office x-rays of our case presented, and these are his x-rays 2 years after surgery. He also had CT scan that confirmed union at that time. So who is a candidate for this procedure? Patients aged 40 years or less with symptomatic non-union and non-salvageable proximal pole, often in the revision setting, are candidates for an MFT. We must also consider the donor site. Patients with prior surgery or trauma to the ipsilateral knee can be considered for a contralateral LFT, but should not be considered for an ipsilateral MFT. Also, due to recent research and our experience with these patients, we know that patients with higher BMIs tend to have worse pain and less favorable outcomes on the donor knee. For all patients, but especially these obese patients, we have a very pointed discussion about the possibility of donor site morbidity. So far, I've presented a procedure that replaces like with like, meaning we replace the proximal pole with vascularized bone and cartilage to restore normal anatomy. I've also described the ideal patient for this procedure. But does this procedure work? Does the complex MFT result in a healed non-union site and improved patient outcomes? In 2013, Berger and Higgins reported favorable outcomes of their first 16 cases. All but 1 went on to CT confirmed healing. All experienced some relief in their wrist pain, with 12 out of 16 experiencing complete relief. Patients neither gained nor lost range of motion, and it should be noted that this is not a procedure to improve wrist stiffness. Next, the same team looked at donor site morbidity. They found that knee pain was present, but time limited. Patients maintained full range of motion of the knee and had no instability on exam. Imaging, including MRI, showed no pathologic changes, and the harvest site filled completely with fibrocartilage. There was also no osteophyte formation. Most recently, we've evaluated the 2-year outcomes of these patients. 98% achieved union. We found no progression of carpal collapse and showed improvement in radiolunate angle from extension of the lunate preoperatively to neutral postoperatively. Similar pre and post-op range of motion were again noted, and DASH scores improved by 15 points. A mild decrease in patient-reported knee outcome measures was seen, but did not reach clinical significance. However, as mentioned previously, higher BMI was found to be predictive of worse lower extremity and global outcomes. Lastly, you may be wondering, since the microvascular anastomosis of this procedure makes it more complex than the other options, does the vascular inflow even matter? This study from 2018 on a pig model would suggest that, at least histologically, the vascular perfusion is important. Osteochondral grafts supported by synovial imbibition alone were compared with those supported by both synovial and vascular pedicle perfusion. They found better cartilage quality and survival in the vascularized grafts. It must be noted, of course, that the clinical relevance of these histology findings is unknown. So in summary, 6 minutes is not nearly enough time to describe just how excellent the MFT is, but I hope I've been able to show you that the MFT is an outstanding option for the non-salvageable proximal pole nonunion in a young active patient. We replace like with like by bringing in vascularized bone and cartilage with anatomic restoration. The waist level osteosynthesis with its new blood supply is able to reliably achieve union. The cartilage remains viable via both subchondral perfusion and synovial imbibition. And the literature demonstrates improvement in patient clinical outcomes. This would be our approach to Dr. Huang's patient. Thank you very much.
Dr. Thayer, thank you very much. That was a wonderful presentation, and always going first can be a little bit daunting. You always have phone a friend. Dr. Higgins is on the line as well. And so what we'll do is we'll run through the other presentations, and then we'll do questions at the end. It's a privilege now to introduce Dr. Chelsea Bowe from the University of Washington, mentored by Dr. Jerry Huang, who will be talking about the proximal hamate for this condition. Chelsea.
All right, thank you, Dr. Kakar. Share my screen here. All right, good afternoon. Thank you for the opportunity to participate, and to my faculty mentor, Dr. Huang. Proximal scaphoid fractures with small, partially avascular fragments, which cannot be fixed with standard implants or who have failed previous fixation attempts, represent a significant clinical challenge. Treatments can be broken down into fixation, reconstruction, and salvage. When fixation is not feasible and the patient is not a candidate or is unwilling to explore salvage options, we really have 3 reconstructive options. In assessing between these options, the first question is that of vascularity. This is an article from the group at HSS that assessed this question. These were 35 patients treated with non-vascular grafting. Despite the fact that there were abundant signs of impaired vascularity in over half of the patients, the vast majority of these patients went on to heal. They concluded that vascularity is not required. Vascularized grafting is rarely required. These are also not without significant morbidity. This is the study that was previously described. They reviewed 252 patients and found that only 71% of the MFT patients had good outcomes. Another way of looking at that is nearly 1/3 of patients could no longer regard their knee as good after the procedure. There also were reports of fracture. Unfortunately, these are not the only reports in the literature of fracture following these grafts. In one case, this ultimately required a total knee arthroplasty, which is a high price to pay in a young patient for a bone graft. Rib grafting is certainly another option. In this case, they describe small holes in the parietal pleura, which, quote, should not create a problem. And they describe hemothorax and 2 months of persistent pleural effusion as minor problems. Thankfully, we do have another choice. The proximal Hamate autograft was first described in this case report from the Mayo Clinic. It's taken from the, as shown here, rotated 180 degrees and represents an excellent match to the proximal scaphoid as seen in this on the right. It also represents an opportunity to repair the scapholunate ligament as it is harvested with the volar capitohamate ligament. This patient was followed for 3.5 years and had a Mayo risk score of 90, representing an excellent outcome. They reported the value of this as a single incision and the absence of microsurgery for this graft. Just how well does the graft fit? This is a morphometric analysis from the University of Washington evaluating this graft and comparing with the proximal scaphoid. This was a cadaveric study, and they ultimately concluded that these grafts were similar in height, weight, and sagittal radius of curvature. A similar study was performed at the Mayo Clinic using 3D CT modeling in which the proximal hamate was reversed and overlaid on the proximal scaphoid. They found in the majority of cases there was greater than 90% agreement within 1 millimeter between these two grafts. When we assess the donor site morbidity of the proximal hamate, we have excellent biomechanical evidence that there is minimal impact to the carpus. This study, they evaluated the wrist in multiple planes of motion and found that there were no differences in capitolunate or scapholunate axis angles. Thus, they concluded there was minimal effect on carpal kinematics. The technique for this procedure is relatively straightforward. It's a dorsal wrist incision, a ligament-sparing capsulotomy a la Dr. Berger. This is the appearance that was shown in the earlier slides, where you have essentially an eggshell of cartilage and subchondral bone, which is often fragmented. This is resected, and the defect is enlarged to healthy, stable bleeding bone. This is then measured, and the hamate graft is harvested from the same incision. This is reversed and provisionally pinned in place as seen here. This is replaced with a headless compression screw, and then the scapholunate ligament can be repaired or fortified with a suture anchor as seen here. This is a patient 6 months out from said grafting. You can see that the graft has healed, the alignment is excellent and well maintained, and he has a normal scapholunate interval. There are a few technical pearls for this procedure, the first of which is to reflect the scapholunate ligament from the proximal scaphoid to leave you abundant tissue for later repair. To the similar end, you protect the volar capitohamate ligament during the graft harvest to augment the repair. There is a limit to the size of graft you can take based on gender and patient size. Really, you're limited by the capitate facet, but typically 8 to 10 millimeters can be reliably harvested. The graft is also rotated 180 degrees as diagrammed here, such that the capitohamate articulation becomes the scapholunate articulation. In conclusion, we've come up with a flow chart for how we approach proximal scaphoid fractures. Our first question is, can it be fixed with customary implants? If the answer is yes, the scaphoid can be fixed in a procedure that is relatively straightforward and most hand surgeons are comfortable with. If the answer is no, then we ask the question, do you enjoy microsurgery? If the answer is yes, we ask, do you enjoy 5+ hour cases? If the answer is yes, we ask if you have a strong dislike for your patient's knee. Again, if the answer is yes, then an MFT is a wonderful graft. If the answer to any of these are no, then you have to ask the question, did you become a hand surgeon because you really enjoy being inside the chest? If the answer to that is yes, again, the rib autograft is a wonderful choice. If the answer to that is no, if you would prefer a single incision graft, no microsurgery, and a shorter procedure, I don't see how you can beat a proximal hamate. Thank you.
Dr. Bo, talk about turning up the heat. I think that last slide got a lot of applauses. My phone is firing up here, so congratulations. And it was interesting for me to see the power of Dr. Higgins, because I think the first author on that paper that you showed was Mary Kate Thayer. And if memory serves me correctly, she just spent the last 6 minutes saying how good the MFT is. So, you know, hats off to Dr. Higgins in Baltimore there. Okay, I would hate to follow that, but Dr. Jake Gire is talking to us from Stanford on the merits of rib autograft, being mentored by Dr. Jeffrey Yao. Jake.
Great, thank you. So my name is Jake Gire. My mentor is Jeffrey Yao, and I'm going to be advocating for the rib autograft today, specifically for the unreconstructable proximal scaphoid. So the reason this is a good choice is we know that it's reproducible, and we've had multiple groups demonstrate reliable healing with acceptable outcomes. The donor site, you don't have to be scared, has been in use since at least since the 60s, and specific to this indication, we've been using it for 30 years. In the literature, Dr. Sandow publishes early results with 47 patients. 85% of those had good to excellent results at a median of 15 months. There were no non-unions, no major complications. Yes, he did mention the hemothorax and the pleural effusion, both of which resolved without any intervention. Dr. Veach in his group had 13 out of 14 patients with good to excellent results at a mean of 5 years follow-up. They all had improved grip strength, range of motion, less pain, and no degeneration or deterioration of carpal alignment, no non-unions, and no complications in this group. Again, Dr. Yao in his series with a minimum of 3-year follow-up showed improvement in functional outcome scores, improvement in grip strength, and no complications. Beyond these short-term studies, which the other techniques have, we also have long-term follow-up data, which is unique. In 2013, Dr. Sandow was able to publish or discuss his 10-year follow-up data, 40 patients with a minimum of 10 years, of which 3 out of 4 had no to mild pain, 92% considered surgery a success, 90% survival rate with only 10% requiring further surgery, and the donor site complications, which had previously been discussed. Outside of this specific indication, hand surgeons have been using this graft for other indications with good outcomes. For example, in 72 patients with OCD of the capitellum, this graft has been utilized with 70 of 72 of those returning to their sport with a mean follow-up of 5 years. It's also been utilized for arthroplasty of the PIP and MCP joint with a mean of 6-year follow-up up to 11 years of follow-up, again with good outcomes and no issues with donor site. This graft is robust. It's a big piece of cartilage and bone, which can be utilized in a variety of situations. On the left, you can see an example of 11 years after arthroplasty of the PIP joint. Next to that is some fine whittling, really shaping the graft to fit whatever need you have. People have used it for post-traumatic reconstruction and complex elbow fracture dislocations, reconstruction of the MCP head after trauma, as well as resurfacing of the trapezium. The other advantages of this technique is the donor can be done with a single team without need for a microscope, and the patient can walk out of the surgery center. So don't be scared. The rib donor site, although we in hand surgery don't have robust series, because it's been utilized by a variety of different people for a long time, there is good data to show that the donor site is not bad. For example, in a meta-analysis of about 500 patients, they found the pneumothorax rate of 0 to 0.3%. Most common complication was hypertrophic scar in 5 to 13%. Hematoma, which self-resolved in 5%. No issues of chronic chest wall pain or intercostal neuralgia. No functional limitation identified. And in most series, in people who are using this graft, they talk about chest wall pain being for a couple days to a couple weeks. Again, not affecting long-term function. So getting back to the case at hand, we agree, this, we've identified it is not salvageable. So we've decided to proceed with rib autograft. Our technique, we're aggressively debriding until the scaphoid looks normal. From that point, we're going to the rib. You pick a rib 4 to 7. It's usually along the mid-clavicular line, and you can use a 21 gauge needle to identify where that junction between cartilage and bone is and center your incision there. It's easy to get down and use a rib elevator to elevate it off of the pleura. A 15 blade can be utilized to cut the cartilage, and then an oscillating saw or a rib cutter for the bony component. From there, we're maintaining about 2 to 3 millimeters of bone, and then we're using a scalpel to shape the robust cartilage graft to fit whatever defect we need. Our goal is to overstuff, and then in addition to that, we're suturing the SL ligament to the perichondrium to address the carpal mechanics component. For follow-up, this is a 2-week example follow-up of a patient who had this for their small proximal pull that was not salvageable. We're following this. They're being immobilized, and a CT scan is utilized to identify coaptation between the graft and distal scaphoid. Here you can see the bone which has united with the distal scaphoid. The pins are then pulled, and we're following long-term with simple radiographs, again, for carpal height and alignment. Here's an example of a patient 2 years post-operative after rib autograft. And here's an example of a CT scan of that same patient showing what this looks like after things have remodeled. At 2 years, here are his range of motion outcome photos, and then symmetric grip strength on Jamar grip testing. Thank you.
Thank you very much, Jake. Very well put together. Very nice case that you showed. Okay, bringing it home now is Dr. Kate Bellevue, mentored by Dr. Mark Richard from Duke University, talking about can we actually fix these as opposed to replacing the proximal pole?
All right. Thank you for that introduction, and thank you for the opportunity to speak today. While the options previously presented all have their merits, they're all quick to discard the proximal pole of the scaphoid entirely. Following AO principles to repair proximal pole nonunions restores the native anatomy and biomechanics of the scaphoid and the SL articulation, as opposed to trying to reconstruct them. Attempts to repair the scaphoid are warranted and can be readily combined with different methods of fixation and numerous bone grafting options to augment the repair. You can cater your skills to the specifics of the patient in front of you, their anatomy, and their needs. For the skilled hand surgeon, the world is your oyster. There are many fixation options, the most common being headless compression screws. Garcia et al. Reported on the Duke experience of using 2 headless compression screws for management of scaphoid nonunions. This was a heterogeneous group of scaphoid nonunions, including those at the proximal pole, and were treated with 2 headless compression screws and either a corticocancellous graft from the iliac crest, a capsular-based distal radius graft, or a medial femoral condyle bone graft. All 19 nonunions had clinical and radiographic evidence of union. Images of a patient with a proximal third scaphoid nonunion reveals evidence of union after 3 months on plain films and on CT scan. Here are images of a patient who underwent 2 prior surgeries at an outside hospital for non-union of a proximal pole fracture and subsequent avascular necrosis, referred for treatment with an osteochondral graft. However, the patient was successfully treated with 2 micro headless compression screws and a corticocancellous iliac crest graft, which healed. K-wire fixation is another option. Meisel et al. Report on outcomes of K-wire fixation and iliac crest cancellous bone graft in 32 patients with scaphoid nonunions. Union was achieved in 100% of patients, including the 44% that had proximal pole fractures. Scaphoid volar plating is successful in management of nonunions as well. Putnam et al. Studied 13 scaphoid nonunions with AVN, 12 of which were proximal pole fractures. Surgical management involved a volar incision, reduction, cancellous bone graft, and application of a volar locking plate. 100% union was observed. Fixation can be combined with a multitude of autogenous bone grafts. Bone graft options include non-vascularized grafts, such as cancellous or corticocancellous, and vascularized bone grafts, including pedicled and free autografts. Looking specifically at some of the frequently used vascularized bone grafts, the 1-2 intercompartmental supraretinacular artery autograft is a commonly used vascularized bone graft in scaphoid surgery. However, union rates in the literature are variable. Chang et al. Reviewed the outcomes of the 1-2 ICSRA graft on 48 scaphoid nonunions and found a 72% union rate in the proximal pole fracture subgroup. When looking at fractures with AVN of the proximal pole, 50% of the fractures united, in contrast to 91% of fractures without proximal pole AVN. Some advocate that this particular graft not be used in small proximal pole fractures with AVN or those associated with carpal collapse. In contrast, other vascularized bone grafts have demonstrated consistent success in proximal pole fracture nonunions, AVN, and carpal collapse with humpback deformity. In this study out of the University of Pittsburgh, the outcomes of a capsular-based distal radius graft were reviewed. 89 patients with symptomatic nonunion at the proximal pole of the scaphoid were treated with a vascularized graft from the distal radius attached to a capsular flap of the dorsal wrist capsule. The scaphoid was fixed with a cannulated screw, and fixation of the graft with a microsuture anchor was used in most patients. 85% of the non-unions healed, and an 84% union rate was observed in those with proximal pole AVN. Sommerkamp et al. Specifically looked at treatment of scaphoid non-unions with proximal pole AVN and humpback deformity. 15 non-unions of proximal pole were evaluated with AVN, 73% of which included fractures of the proximal third of the scaphoid. All were treated with a pedicled palmar radiocarpal artery vascularized bone graft, secured with retrograde internal fixation, 100% united with maintained correction of the humpback deformity. Here, patients with the complex problem of proximal pole AVN and carpal collapse were successfully treated while limiting dissection to one incision on the volar aspect of the wrist and avoiding the additional complexities of free microsurgical tissue transfer. And finally, for those who advocate turning to the knee to manage scaphoid non-unions, free vascularized medial femoral condyle autografts have shown great success rates. Poulos et al. Examined MFCs in 49 patients with prior surgery for scaphoid fracture who went on to non-union and proximal pole AVN. There was an 84% union rate in this group. MFCs have also been shown to be successful in instances with proximal pole AVN and carpal collapse, with 100% union in all 12 patients in this series out of the Mayo Clinic. And notably, the entire SL ligament is spared in this technique. Now let's take a closer look at the other proposed options. MFTs use vascularized bone graft, but sacrifice the SL ligament. There is an attempt to preserve the distal SL ligament, but how much is really preserved? And the majority, if not all, of the dorsal strong portion of the SL ligament is sacrificed. And one can't forget about the large whack on the knee. Looking at knee donor site morbidity, 9% of patients have constant daily knee pain. 22% have intermittent knee pain, and 20% are limited in their ADLs due to knee pain. 20%. So 1 in 5 patients can't perform their ADLs without knee pain. So now you take a patient who has one painful extremity and give them a second one. Rib autografts are non-vascularized without true ligament reconstruction. An attempt is made to reconstruct the SL ligament with perichondrium, but this is physiologically different tissue and is a poor substitute for a ligament. Furthermore, the risk of harvest should not be taken lightly. Hemothorax, pneumothorax, pleural injury. Although no studies have reported infections, the chest wall is a suboptimal place for infection. And the proximal hamate involves less donor site risk and morbidity, but again, is non-vascularized. Attempts are made to reconstruct the SL ligament with the captohamate ligament. We all know about the difficulties around repair and reconstruction of SL ligament tears. What makes us certain that a reconstruction with the captohamate ligament will fare any better? In conclusion, fixing the scaphoid in the setting of a proximal pole non-union is possible and successful in many instances, and we believe this can be done in the case presented with a small proximal pole fragment. There are versatile options which you can cater to your patient. You can take a non-vascularized graft, a pedicle graft, a free vascularized graft, all while preserving the native anatomy and the SL ligament. And the outcome of your surgery is not necessarily dependent on large donor site morbidity. Success really just takes a good hand surgeon, one worthy of the title Scaphoid King. Thank you.
Okay, I love that picture about Mark. I didn't think anyone else saw that about him, but I'm glad that you could share that now. I've been holding that for the last decade. Wonderful picture. All right, there are 4 fantastic presentations, and really I'd like to thank all the fellows there taking the time out to give a nice, succinct review of the literature and their technique for this. Now, I think we want to also give a little bit of love to the attendings taking care of them. So I think a lot of the questions are going to be directed to them. And if you have any questions, please send them in. So I think the first question, what I'd like to do before we talk into the nuances of technique is, I think the initial presentation talked about the study out of New York, questioning vascularity and avascular necrosis and intraoperative punctate bleeding, which has traditionally been the gold standard that we've been taught. So first question to Dr. Higgins. Jim, when you're seeing these patients preoperatively and you're thinking about the vascularity, are you judging this based on imaging? Is this still an intraoperative decision for you?
Yeah, I think that's sort of boy, there were so many points in so many different directions here, but Sanj, you can hear me, right? I'm coming through. Okay, good. So that study, the Ranci et al. Study, was quoted by Chelsea in the very beginning of this, and it's really does not really appertain to this discussion for a number of reasons. I think what that group from New York has done really well is show us that the ability for us to predict or detect or diagnose AVN is really failed. There is no gold standard. There is no reliability between different methodologies, whether it be MRI, CT, MRI with contrast, X-ray, or punctate bleeding, or histology. So their conclusion was absolutely correct that AVN is not something that any of us can say with reliability, nor can we interpret any of these studies that have a certain percentage of AVN patients as being accurate. So I don't even look at AVN as an indication for or against vascularized bone grafting. I think that the leap that Ranci et al. Takes in both of their studies, and they put out one other installment in hand clinics, was that they included a series of patients with very minimal risk factors, where they used non-vascularized bone grafting and said, hey, I just went through these great lengths of telling you all that we can't reliably diagnose AVN. And by the way, here's some cases that we cancellous bone grafted waist fractures on, where 72% of the patients were all primary surgeries. So there's very few revision surgeries. 74% of them were distal, waist or distal, so they were not proximal poles. And only 30% of them were displaced, if we define displacement as DZ deformity, cystic resorption, or millimeters of displacement. So to conclude from a really great study like Ranci et al. Put out, that AVN is hard to diagnose is correct, but then to sort of piggyback on a small series of low-risk candidate patients that underwent cancellous bone grafting and conclude that vascularized bone grafting is no longer indicated is completely unrelated conclusion. So it's sort of apples to oranges. I sort of wish that they had not inserted that in the paper. I think they go to great lengths to point out that a lot of studies will say that AVN is the primary indication for vascularized bone grafting historically. And that's true, but I think all of us on this interchange here today would agree that there's a number of other very important, perhaps even more important risk factors, including previous surgery, the location of the fracture, meaning how proximal is the proximal pole, the smoking status of the patient, the displacement of the fracture, duration since fracture time. These are all hugely important. And so you can't look at any one patient and say, this patient needs vascularized bone grafting or not, or conclude that our inability to diagnose AVN rules out the need for vascularized bone grafting are completely unrelated. So I find that to be a frustrating discussion, Sanj, and that's why my answer is so long, and I apologize.
No. Thanks, Jim. No, there's some important points there. And for the sake of time, Journal of Hand Surgery did a debate between Jim Higgins and Scott Wolf. So I urge all the fellows at least to listen to that. It was supposed to be a half-an-hour debate, and there's an hour debate in the end. So thanks for that. What about you, Jerry? In your practice, when these patients come in, how are you evaluating them and determining vascularized or non-vascularized grafting?
So I think I agree with a lot of Dr. Higgins' points. I think if you look at the literature on proximal pole non-union AVN, it's kind of lumped together. But there are a couple of recent meta-analysis that really looks at this. I mean, what's considered proximal? Is the proximal 1/2, 1/3, 1/5? Also, has the patient had prior surgery? What are you really working with? How much of a defect are you dealing with? So I think that's an important conversation. I think if you look at your more standard proximal 1/3, I think I agree. A lot of those patients who never had surgery probably would do well with your standard ORIF with cancellous bone grafting. They probably do pretty well with that surgery. I think the carpentry stability is probably as important as the blood supply. But for the case example we showed here, where it's a very small proximal pole or somebody who's had failed surgery, I think that's really the key. I don't think MRIs are really that helpful for me. I've actually gotten away from MRIs in general. There's a lot of false positives as far as AVN as everybody knows. So I think I really looked at the size of the fragment, how much combination, what am I dealing with as far as the patient themselves and the tissue I'm dealing with. So I will go in with a more of a, if it's a proximal pull, the fairly substantial size, I'll go in planning on doing non-vascularized bone grafting, but a very, very small proximal pull. My go-to is a 1-2 ICSRA. I think blood supply doesn't matter when it's a very, very small fragment. But the one approach I've done is go in with a approach of trying to fix it with some type of vascularized bone grafting, but the proximal hamate becomes my bailout. So if intraoperatively that proximal fragment kind of blows apart, or I feel like I don't have a really good fixation, that's why it's really nice to have a ipsilateral incision in the same area where your bailout, your kind of salvage is right in the same incision, so it makes it a lot easier.
So in the OR, Jerry, are you putting the tourniquet down to look at the retrograde blood supply or not?
I used to, and kind of look for that punctate bleeding to assess AVN or not. I feel like it hasn't really changed what I do. So I think I will go in with a very small proximal pull, plan on doing a vascularized bone grafting. I feel like I'm right there. It does make it a little bit more complex procedure, but it's really the same incision. So my plan going in is essentially predetermine what I'm going to be doing, vascularized versus non-vascularized.
Jeff, anything to add when you see these patients?
Not to beat a dead horse, I would totally agree with what Jim and Jerry have already talked about. I think the one point that Jim brought up, which is really important, is that not all these patients are exactly the same, and to have a really dogmatic algorithm for every patient, or that would fit every patient that walks through your door, is problematic. And that's the beauty of this debate, is that, you know, depending on which patient you have, you can argue that all of these techniques can be used for a particular patient. And I think we've all used all of these techniques. So it's not to say that any of these techniques are incorrect. I tend to, when it comes to the actual patient, I tend to be a little bit more on the aggressive side, in the fact that as my fellows will attest to, I tend to use a lot more vascularized graft than probably is needed. And my argument there is that you have one sort of chance to really get this bone to heal. And I like to call it this kitchen sink approach. I throw everything at it. And I like to use pedicled grafts, particularly if the pole is salvageable, with either from a volar approach, a volar carpal artery pedicle, or the dorsal approach, either Dean Saturnianos' graft or the 1-2 ICSRA. And
how are you making that decision, Jeff, going dorsal or volar if you're going to put a graft in?
So it depends on the morphology of the scaphoid. If there's a humpback deformity, I'm not confident that a dorsal approach can adequately reduce that humpback deformity. And so then in that case, I'll usually go with the volar approach and get a nice wedge of the volar distal radius, which is attached to the volar carpal artery as my pedicle, and rotate that in there. And I like to put a plate on there to sort of support the construct. If it's just a proximal pull with no significant humpback deformity, then I'll go dorsal usually, because the approach to the proximal pull is much easier from the dorsal side.
Yeah, there was just a nice article in Journal of Hand Surgery, I think Jeff Greenberg's series of using the Palmer graft with excellent outcomes. Mark, Kate gave a nice talk about fixing the proximal pole. So in your mind, you know, there was some data there, 1 versus 2 screws. Jeff just mentioned plating. What are you doing with a very proximal pole fracture? Are you going dorsal with the dorsal vascularized graft, or are you going volar? And how do you determine between screws versus plates?
Yeah, great question, Sanj. And I think one thing to keep in mind, even 30,000 foot view, is that the broader your bag of tricks and the wider your armamentarium, the better you're going to be. And I think all of us on here would agree that if we could be as good as Jim is with the MFT, as good as Jeff is with the rib, as good as you and Jerry are with the hamate, and as good of a carpenter as we can all be with our orthopedic and plastic surgery principles, that's what we choose to do. So while it's fun to do it in the competitive style, I think we're all a little jealous of each other's little niches on this. So the more that you can learn and the more you can be better with all of those and have a broad bag of tricks, the better you're going to be to take care of these. And how that answers your question is that I think these injuries are heterogeneous, and they're really a spectrum of injury. And the proximal pull is interesting because it eventually goes from being a fracture to a ligamentous SL injury. And somewhere along there, it stops being a bony piece that you can fix, and it functionally becomes an SL injury that happens to have a little piece of bone on the end. And we're really arguing about where that line is and where you want to push it, and then what your options are. And I think it's good to have all of them in your bag of tricks. But to specifically answer the question, I'm going dorsally on these. And I think having different size screws, knowing the limits of your cannulated compression screws, to my knowledge, they come down to about a 1.7. Using combinations of things. Kate put Milan Stavanovic's paper in there on the K-wires, showing you can get union, you can get derotation capabilities from K-wires as well. I think Tom Trumbull 25 years ago had a paper looking at that. So you really have to keep your antenna up for all your bags of tricks. And then the last thing I'll say about it is, we're talking about vascularized graft, non-vascularized graft, but it's really important to remember the technique of bone grafting. You want to be really fastidious with getting all the debrided non-vascular tissue out of there and doing a very good and conscientious job of packing as much graft in as you can. A bone needs two things to heal. It needs biology and stability. And your job there as a surgeon, whichever of these techniques you choose to employ, or to provide those two things and leave the operating room knowing that you have those two things imparted to the scaphoid.
So Mark, you make some excellent points as always, and you mentioned about excising the proximal pole. So in your mind, how big a piece can you excise and you're comfortable with doing that?
Yeah, it's I don't know that I can give you an integer to answer that, or a discrete answer, but again, at some point it comes down to your intra-op observation of things. There are some PLLA or some absorbable pins that you can use for some of these things. You can use a K-wire and bend it around the corner if you think there's enough. Immobilize the wrist and just plan to come and take your hardware out. Jerry and I actually had a webinar last night on scaphoids, and he showed a case where he purposefully left a screw a little bit proud so that he didn't comminute that piece. And I think that's all intraoperative decision-making. And it goes back to the adage that, unfortunately, good judgment comes from bad judgment and experience. Good judgment comes from experience. Experience comes from bad judgment. So I think we've all done that little trick where you do it just a little bit too much and you see some kind of complication that helps you the next time around. I certainly know I've been there, but those are the things that make you a better surgeon the next time and let you make that intraoperative decision-making with the bag of tricks that you have.
I just wanted to ask Jim a question that came in. Mary Kate talked about the acetabulum when you're doing the reconstruction. Now, sometimes the proximal poles can get slightly larger, and it's involving the scaphocapitate junction. So can you talk to us about your tricks about how you then fashion the graft to address the scaphocapitate articulation and the radiocarpal articulation?
Right, so I'll just say Mary Kate did, as anticipated, an awesome job and must have been trained well somewhere before she came to us. But the presentation showed really nicely the resection of the proximal pole resects the greater arc of curvature of the scaphoid and preserve the so-called acetabulum, meaning even if the non-union line, let's say it was a revision surgery and a patient with a lot of risk factors like a long duration from injury and a significant instability pattern, previous instrumentation, etc. And we decided to do an MFT. We would preserve the entire mid-carpal capsule. And one could argue that the distalmost aspect of the dorsal and volar SL ligament are involved in that. And I think that's probably true, although I think it's irrelevant. But we keep all of the concave acetabulum of the scaphoid, even if that includes a portion of the non-united proximal fragment. We then overstuff, as was mentioned about the rib graft as well, and I think I've spoken to Michael Sandow about this a lot, and I think we all recognize that overstuffing is probably a very real entity. We try to make that graft as big as we possibly can to expand the space. And how I visualize it is I'm asking the flap to heal to the distal pole as well as the acetabulum of the mid-carpal joint. So we actually never see, imagine doing the surgery and you actually never see the capitate purposefully. And I think that serves us well because, as Mary-Kate rightly said, we only bring a convex portion of cartilage that effaces the scaphoid fossa. We do not bring any concave cartilage that would do anything to serve to resurface the mid-carpal joint.
Thanks, Jim. We only have 9 minutes left, and a lot of people are saying we want the gloves off. And so given that, and we're talking about complications, let's say this is your wrist. We're going to start off with Jeff Yao. This is your wrist, and you have this problem. Are you honestly going to go to your chest to take a rib graft out if this was your wrist? Don't say it's somebody else's. This is yours in your prime of your career right now. What would you do?
Let me make sure I'm off mute here because I want to make sure my message is heard loud and clear.
We can hear you.
No, listen, first of all, like I said earlier, I want to applaud our fellows. I think they did an outstanding job. I want to applaud all the faculty mentors too, because clearly they were coached up very well. And of course, all these techniques have their place. In my mind, and for this particular fracture, if I had this particular fracture, I think if I went the ORIF route, even if Mark was doing it, I'd be looking at 2 surgeries at least. The second surgery to probably revise that, because that piece is just a shell, and I'm not confident that was going to heal. And then the Hamate is very attractive. Don't get me wrong, and you're a really smart guy, Sanj, and I think that's a great option. It's 1 incision. My concern there is that you have that huge hole there now where the proximal hamate used to be, and that articulation between the hamate and the triquetrum is going to be lost. So what is that going to mean? I know you did that nice study, biomechanical cadaveric study, but if you look closely at that, I think you had only about 100 cycles where you cycled the wrist. So 100 cycles, at least in our daily life, is maybe 1 day of activity. So what's the long-term implications of not having that proximal pull of the hamate there? That concerns me. Alternatively, for my chest, I mean, I have multiple ribs there. I can probably spare 1. I would go to my one of my mentors, Rod Hentz, who taught me this technique, and I would probably have him do that for me. I'm not sure I would want somebody messing around with my knee again. MFT, I think, is a great procedure, Jim. I'm not here to throw stones, but I'm not sure I want another incision in my knee. I'd rather have one in my chest than my knee. And for those of you who are concerned about the morbidity, I think the morbidity or the risk of operating on the chest is actually really low. I was initially concerned when I first did it. But if you think about it, I mean, if you can put a finger on, you can operate on the chest wall. It's really not that hard. So that's what I would do.
So you're comfortable walking around with a chest tube. That's good to know, Jeff. I think honestly, the hamate, that's Bassem El Hassan's brainchild. He's a technical wizard, thinks out of the box. So hats off to Bassem for teaching me that technique. What about you, Mark? What would you do if this was your wrist?
With my wrist, I agree with the start of Jeff's comment, but not the end of it. In that, I like the procedure that does not have a donor site morbidity, and I would take the risk of a second surgery to avoid that donor site morbidity. So the way I think of it, I like to take the steps 1 step at a time, not 2 steps at a time. And I think there's probably little risk to having an attempt at ORIF with a local bone graft. Keep it all in 1 site. And then if that fails, it doesn't necessarily rule you out of any of these other options. So my personality and my risk reward profile would be most consistent with truly having it fixed first and considering these other as salvage operations. And again, I think that they're wonderful advancements in hand and wrist scaphoid surgery. So I'm not belittling them at all, but I think this one makes sense for me to do 1 step at a time, have an attempt at reconstruction. It's not a multiply operated procedure yet, and go from there.
So with the case that was presented, Mark, obviously you'll tell the surgeon where to go, dorsal or volar, screw or plate. What would you have done for that case? Would you have gone dorsal, 1-2 with a small screw, what would you have done?
Yeah, for me, I'd go dorsal for sure. You know, Scott Edwards and Jill Putnam, they showed very nicely in their series some really proximal fractures captured with that plate. I've used the plate a little bit, but not enough to feel comfortable with it. And that is incredibly small piece that Jerry showed there in that case. So I would go dorsal, go where the money is. And I've been a big fan of Dean Saterianos for not previously operated wrists. That capsular-based flap has been really pretty robust for me. So that's what I would do in that situation. Okay.
So Jim, you're very active. Obviously, we heard about the knee pain and morbidity. Obviously, your BMI is not what was shown in terms of complications. But if at your stage of your career, are you honestly telling us you would have an MFT for this?
No, and I think, Sanj, you know, this is, as much as we have a tendency in these fora to want to be entertaining, it really detracts a little bit from sort of the diagnostic process and the decision-making process. Nobody on this, I hope, no one on this conference should take ownership of their operation they've been assigned to here. So to be clear, you know, there are no dividends being paid by MFT, you know, LLC for us. Sure. And I'll say that patient there, I would have offered a vascularized bone graft, a local vascularized bone graft, and particularly if it was a younger patient and it was my child, because I think that's a little bit more relevant question. Typically, these are 17 to 20-something-year-olds. And to also be clear, as Mary Kate said, we don't offer MFTs to anyone who's in their mid-40s or over, which would eliminate most of us. I was going to take a shot at Jeff there, but I'm not sure exactly how old he is. But and the reason for that is, you know, there's a multitude of things you've got to consider carefully. You're trying to beat the natural history of the disease process. And also, you've got to think of the ability of the patient to rebound from the standpoint of the knee. So in the mid-40s, when everyone, myself included, gets meniscal repairs after, you know, running marathons and things like that. So I think performing that operation in those older patients makes it very unlikely that they'll rebound as quickly as younger patients. I'd say the last thing with regard to morbidity to the knee, clearly you've got to identify risk factors, and you've got to explore these things if you are doing any sort of surgery that is novel and in a responsible way. Chelsea mentioned fracture. Now, the data on fractures for MFCs, for an MFC flap, that's a cortical cancellous flap for long bone non-union. So that's apples and oranges. It has nothing to do with the MFT flap. So I wouldn't want anyone walking out of this educational forum and concluding that there's a reported instance of fractures of the femur from a 1.5 by 12 millimeter harvest of cortical cancellous or osteochondral flap from the trochlea. So there is morbidity associated with it. It's associated in patients with heavier BMI. There's no fractures associated with it, but I certainly would not have it. And I'll just say I'm 51. I would not have it myself, and I would not offer it, and never have offered it to anyone in excess of 45 years of age. So I'd be getting Mark to take a swing at my scaphoid, and I do firmly believe in that. I think that if you have an opportunity, albeit a high risk, an identified high risk non-union, there is a lot of merit in attempting to decrease the morbidity with a local vascularized or even non-vascularized bone grafting procedure. But we shouldn't get confused by what we do a lot at our institution, or you know, what we think is a big hammer that we're getting used to, and everything starts looking like a nail.
No, great points, Jim. You're absolutely right. We have to stratify these based on the patient and the fracture characteristics. So if this was yours and you vascularized bone graft local, do you have a preference, volar, dorsal, Saterianos 1-2, or the Palmer one? Which one would you do?
As I recall, and it's been a while now, so there was no DZ deformity, right? It was just a very proximal pull. Mm-hmm. Yeah. So I would approach it dorsally, and I'd do a 1-2 ICSRA, and I'd try and use a very small implant, perhaps even walk out of there accepting K-wires, understanding that there's risks associated with K-wires over, at least in some studies, K-wires over screws. But being most concerned that I think your goose is cooked once you have shattered that small fragment. So you got to concern yourself with hoop stresses. as everyone here is, I'm sure, nodding and saying they're concerned about. And that's why there's the desire for small implants, perhaps even making sure that you pre-drill generously and countersink generously to make sure that you don't destroy the proximal pole. So yeah, I'd have one to ICSRA.
Okay.
Small implant.
Thanks, Jim. Jerry, we're coming top of the hour. It seems poignant to finish with you. Thanks for putting this together. What would you do if this was your wrist?
Yeah, so I echo the other faculty's comments and pearls. I think the fellows all for did an outstanding job on presentations, but I think a really key takeaway is this is not representative of all we're doing at each institution. I think the really point of this is to offer the tools to all the fellows who are in this webinar, that these are all tools to have in your toolbox and really what you're comfortable with. Also having bailout options. I agree with everybody. I think this is my risk. I want some attempt by one of my trusted partners or colleagues that trying to fix it, primarily with some type of vascularized bone graft. I think it's a very small proximal pull. I will want everything thrown at it, like Jeff Yao alluded to, really kind of throw everything in the kitchen sink at it, give a vascularity, give a stability, really do a good job to breathe a non-union, pack it with bone grafting and vascularity. I think if it fails, then I think that's when the salvage will come in. I think for me, much as we do offer the proximal hamate, I feel like somebody who's failed surgery with a combination of proximal pull, I think vascularity probably does matter. A lot of patients, my go-to all the times for a salvage actually is a vascularized MFT for these patients. But for a patient, I feel like that can't be as compliant with follow-up. That morbidly obese patient with BMI of 50, I certainly don't want to venture into knee on the dissection. I think I've had a couple patients who are fairly bigger patients, whether it's keen box or proximal pull, AVN. I just don't think a knee is a great harvest site for them. But I do lay it out with the patient as far as what they prefer, the pros and cons of each procedure. Oftentimes I will bring in doing one surgery versus potentially a salvage that's their one and only surgery. And do they prefer a harvest in the wrist versus the knee? I think it's really a combined decision-making process between the provider and the patient. I think it's a really big part of it. It's just being aware of the pros and cons of each procedure. It's really a big take home for the fellows. It's just really having that honest discussion with the patient on what your options are and what the expectations are with each procedure.
Yeah, no, you're absolutely right. Well, I think that's the top of the hour, just gone past it. I really want to thank the faculty, Dr. Higgins, Dr. Huang, Dr. Yao, and Dr. Richard, but more importantly, the fellows. They've put a tremendous amount of work into this. It is a little bit daunting to do it, and I thought Dr. Thayer, Dr. Bo, Dr. Gire, and Dr. Bellevue did an outstanding job. So thank you very much for this. Dr. Huang, thank you for arranging this. This has been tremendous, and I look forward to learning from everybody as we go forward with other Zoom webinars.
Right, thank you, everybody. So stay tuned for week 2, which will be same time next week. I'll be sending out an email to everybody, but hopefully this is a worthwhile educational experience for everybody. It's great to see everybody across the country, and thank you all, and stay safe.
Thank you.
Thanks, Jerry. Thanks, everyone.
Thank you.
Very nice.